Yeah. From where he?
You have to hit the red button. Just checking in. Oh, I like your dress. Yeah. I couldn't register. Okay.
Shut up.
It's a flow job. Millennial.
Good morning, everyone. I apologize for starting a little bit late. Let's see, we have a full agenda with 2 committee meetings today, so we are going to dive right in. The first thing we need to do is to approve various minutes. Now, I don't know what to say, but there's only one that I can officially move to approve. Is that correct?
So we have a quorum for the Cost Trends and Market Performance Committee. Dr. Wendy Everett is on the phone here today, so we
Good
can.
morning, Wendy.
So we can move forward with the vote for the CTMP minutes, and then I think when we're joined by Commissioner Foley, we'll be able to take a vote on the CHICI minutes.
Okay, so then the first item would be the CTMP minutes of March 29th, and whether anyone has any corrections, additions, or subtractions from them. If not, is there a motion to approve them? So moved. Any second? Wendy, I think I heard you second the suggestion. All those in favor of approving them, say aye.
Aye.
Anyone in opposition? Okay, so those minutes are approved, and then we shall wait for a few minutes for the CHICI minutes. In terms of our just-in-time inventory production, the first item on the agenda is actually Ray, who just came in. So, we hate to do things, with have inventory waiting around here. So we just had Ray come in. So what we're first going to have is a presentation from Ray Campbell, the Executive Director of CHIA, the Center for Health Information Analysis, and then turn into a discussion of performance improvement plans and various strategic investment programs, including the CHART Phase 2 and Phase 3. First, Ray, welcome. Thank you.
Thank you very much.
Come on up.
Thank you very much, Doctor. Thanks to everyone for having us. I think the first, Stephen Page, Deputy Director of CHIA, will start out with the first bit of our information, and I'll be doing some of the presentation after him.
Thank you very much. We'll go ahead and get started if I can. Well,
There we go. Thank you.
So I'm here today to talk about relative price and to talk about our development of sort of a new measure which we've incorporated into our most recent relative price report, and then to further talk about the methodology that we've refined in order to confidentially refer healthcare entities.
Your microphone.
One second, move it closer. Thank you. In order to confidentially refer entities with healthcare with health status adjusted TME growth that we consider to be excessive. So we'll go ahead and get started with the development of a statewide relative price measure. Last year, the legislature developed the Community Hospital Reinvestment Trust Fund, and that fund is to support lower paid hospitals. And one of the criteria for eligibility to receive payments is that hospitals must have a relative price that is no greater than, or is not equal to or greater than 120% of the statewide median relative price. Now, CHIA's relative price metrics have been payer-specific based, so this required that we develop a blended cross-payer, cross-commercial payer methodology. In developing that, we collaborated with our sister agencies and our actuarial consultants, and we additionally held a public comment period, and we published our final methodology earlier this year. So I'd like to just spend a moment and review that because we incorporate this methodology into our P report. So what we needed to do was to develop that cross-payer, cross-inpatient and outpatient, single statewide methodology. So in order to do that, we started with hospital inpatient care, and we developed an adjusted inpatient base rate, and we weighted that for each hospital across its commercial payers based upon commercial revenue at each individual hospital. We did a similar exercise to outpatient using the hospital's outpatient values, and again, weighting based upon each payer, each commercial payer's outpatient payments to the hospital. And then we converted each of those into relativities by comparing those inpatient and outpatient values to the average of values for all hospitals across the state. Our final step was to blend the inpatient and the outpatient together for each hospital by looking at the proportion of commercial payer, inpatient, outpatient revenue and weighting those relativities. The advantage to this really is that we then have a single data point which incorporates inpatient and outpatient. It's weighted by the individual hospital payer mix, and it facilitates a single point of comparison for relative price levels across all hospitals. And the results of our analysis were that we have a range of values from slightly under 0.7 to slightly under 2.0, and the median was 0.93. The upper limit for eligibility of payments for hospitals where payment would be ineligible was 1.112, and the number of hospitals that were eligible were 53, and the number that were ineligible were 10. So now I'd like to move on to our provider price variation, our most recent report, which was published earlier this month. So in this report, we examined acute hospitals using 2015 data, and for physician groups, we used 2014 data, which represents fully settled claims and alternative payment settlements. So it's fully settled data for physician groups. We measured performance where we looked over time. We used our traditional RP calculations, and where we looked at an individual, where we look at performance for this specific year, we used our new methodology, our sort of single blended point of statewide relative price. So when we look at this chart shows us over time how payments have been distributed among hospitals at different relative price quartiles. So what we see then is that payments remain concentrated in the sort of the upper half of hospitals who are paid the greatest amount. If we look at in 2012, 80% of hospital payments went to the half of the hospitals that are most highly paid. And the good news is that when we look at 2015, the most current year, we see that there's been close to a 5% change where lower paid hospitals are increasing their proportion of hospital payments. So that's a positive indication. Our next view is really of each individual hospital's relative price. And this is using our sort of single statewide methodology. And it's organized along our hospital cohorts, which are groupings of similar hospitals. And what we see when we look at this distribution, I should say that the hospital dots are sized based upon the proportion of hospital payments, statewide commercial hospital payments that the hospital receives, and they are color-coded based upon their cohort affiliation. Not on this slide are specialty hospitals, which are really, they're individualized and they're not considered part of a cohort of similar hospitals. So what we see when we look at this is that academic medical centers are paid the highest payment levels, and community high public payer hospitals are paid to receive the lowest level of commercial payments. And this is case mix adjusted, so that's out of the calculation, and it really reflects blended price levels. Okay. I'm going to go on to the next slide, which again looks at each hospital, but this is organized by multi-acute hospital system affiliation. So what we see when we look at, and again, the sizing and the sort of coloration of the circles are similar by cohort or by payment, proportion of payments. And what we see is that the higher paid hospitals tend to be those hospitals that are affiliated with larger healthcare systems that are geographically isolated, which are the circles that are color-coded in gray, open in gray, and specialty hospitals, which are the, I would say, dashed line circles. And you can see that they tend to be paid higher.
What are those two specialty hospitals?
That's Children's and Dana-Farber. In the sort of highest, the highest paid hospitals there, those are the island hospitals in Nantucket and Mountain. So that is sort of the sort of global takeaway here, is that that hospital, this reflects sort of the market, and that hospitals that are part of larger healthcare systems tend to do better. Those that are geographically isolated have higher prices, and those that are specialty have higher prices. So now, sort of turning to physician groups. Again, this is similar to what we saw for hospitals in that we measure the proportion of payments at each sort of relative price quartile among physician groups. And what we see here is that in contrast to hospitals, when we look from 2011 to 2014, our latest data availability year, we see that there's been approximately 5% increase in payments to higher paid physician groups. So just kind of the opposite of what's happening in hospitals. And we tend to look at this sort of in the aggregate over time, rather than consider if you look at 2013, it seems to have a blip between quartile 4 and quartile 3, and that was because one large physician group clicked into quartile 3 and then back to quartile 4 for years. But we do see the trend when we look at the combination of two quartiles. I'm going to now go ahead and talk about our confidential referral of entities to the Health Policy Commission. So CHIA is required by Chapter 224 each year to identify healthcare entities whose increase in health status adjusted TME is considered excessive and who threaten the state's ability to meet the healthcare cost benchmark. We refer those to the HPC, and they may result that those referrals may result in a performance improvement plan pursuant to regulations adopted by Health Policy Commission. In prior years, our sort of bright line referral methodology was whether or not an individual provider or payer's health status adjusted TME exceeded 3.6, the benchmark that was in effect for our 3 prior years. This year we wanted to build a more robust methodology to look at that, to take into account other considerations. So I'd like to review that methodology. So this reflects our proposed methodology. And so if you look at the top, we had sort of our traditional track 1, which was performance in excess of the benchmark results in a referral, and we are retaining that methodology. We also developed our sort of track 2 methodology, if you will, where we're trying to look at rate of growth and then impact. So again, because our statute ties it to rate of growth and health status adjusted TME, we start there and we proposed 85% of the benchmark. So we begin to take a view of providers or payers whose growth is accelerating but not quite all the way to the benchmark. And then we look at other conditions. So are they large? Do they impact the state's ability to achieve the benchmark? So we have a threshold of 2% of statewide member months in order to focus on larger providers. And then we have 2 conditions that we propose. The first of which gets at TME level on a health status adjusted basis. So is the contract that we're looking at, the performance relative to a particular provider with a particular payer, is it above the payer's network average health status adjusted TME level? And if so, in combination with size and growth, we would consider that for referral. The other that we looked at was the unadjusted TME trend. So this is aside from the severity of the patients and how that, or members, and how that may have changed over years, but looking at what's the actual rate of growth, and is it close to the benchmark? And the reason that we consider that's important is because the benchmark itself is not health status adjusted. It's adjusted for population growth, but not for health status. We look at spending and rate of increase in spending on a per capita basis. So this is what we proposed. We then, we had a public process and worked with the AGO and with providers and with payers and industry representatives in order to take comments on our proposed methodology. So one of the items that we heard was that the preliminary data, the data that we get for the most recent year, is too volatile, and we should not be referring them based upon that. And quite frankly, when we examine the trends, we concur with that. We do think it is too volatile. So we've restricted our referrals only on fully settled, finalized data. The other comment that we had here was providers and payers suggesting that the 85% threshold for adjusted or unadjusted TME was perhaps too low, and looked at something closer to the benchmark. And we do think that 85% is appropriate for health status, but we ended up in the final sort of analysis moving to whether the unadjusted TME growth is in excess of the benchmark, just 100% of the benchmark. The next item was opposition to the use of the network average TME threshold, and a proposal to increase it to a higher relative level. So instead of looking at the level at above the network average, we changed that to the 75th percentile. So we're only looking at the sort of top quartile. So those are the changes that we made. And the next slide reflects those changes that we've talked about. Again, we're looking for sort of impact, and we're trying to develop measures to assess that. So what were the results of that, and how did it apply to the data that we were examining for the current year's referrals? So when we look at contracts between payers and physician groups, you can see that we have 24 referrals that were made on like the track 1, just clearly in excess of the benchmark growth rate. And as applied to 2014 data, there were only 2 new referrals that were based upon our combination of growth, size, and level or unadjusted TMP. When we look at the payers as applied to 2014 data, there were no new referrals based upon our methodology. However, we do think the methodology is important, and it's a better framework in order to move forward. So when we do refer entities to the HPC, we try and include as much information as possible to help contextualize the increases that we're seeing. We include health status adjusted TME, the rate and level, both in the aggregate and by the cost components that we collect. We calculate it on a relative basis and include that as well. And we do similar analyses for the unadjusted TME rate and level and member months. And we try and provide as much context as possible to begin the HPC team's deliberation of which entities are appropriate for further follow-up. So that concludes my portion of the presentation, and I just ask if there are no questions.
Let's just pause here.
Sure.
I thought it would be helpful for my fellow commissioners just to explain what happens after this point, so that we then can talk about it as a whole. So the list that you provide us is a confidential list.
Correct.
It's not a public list. That list then goes to the HPC staff, which then takes it and summarizes it for us. So they put together sheets which are, here's what we received from CHIA, here's the organization as a whole, here are the various different contracts, and here's what we're looking at. The staff then will meet with any of us individually, or at least in groups that do not exceed the open meeting laws, so that we can all have a view about what we're seeing and to help formulate a view as to what we should then do. On the basis of that, I believe the CTMP committee has a discussion about what to do. Is that correct? David and Lois?
We do provide updates in the CTMP committee in terms of the review process, but the process document that we approved at the last board meeting potentially contemplates the whole board going into executive session at some point to deliberate.
When we discuss it, it is at that point still in any committee, it is at that point still confidential. And so we would refer to organization A or B or whatever it is as we're discussing what to do. We would then work towards a decision, which would be a commission level decision as a whole, which is whether we wish to, and there may also be feedback from the parties that have been identified. That would again be a confidential discussion with them. At some point then the board will have a discussion again confidentially, either using acronyms, letters, or in executive session, where we would then decide whether to require a performance improvement plan. After that vote, it would then be public what the names of the organizations and what it is that we are requesting. At least on the base of last year, there were the list got smaller between when it was given to us by CHIA and when we spoke to various organizations, because there were a lot of relatively small contracts that had exceeded the benchmark, and so we had those, and we saw that this was one particular contract out of 6 or 7 or 8 contracts for which were tracked, and this one exceeded the benchmark, and the others did not, and so it just looked like it was a relatively small number of people and so on, and we could understand what was going on. And there were other circumstances where particular organizations told us, oh yes, we became aware of that, and we've taken steps to address that, and so on and so forth. So there's a lengthy process that goes on from here, both confidentially with the organizations and amongst the commission. So I think that's a little bit of a background for then what happens after this point. So I suppose the key point is, don't think of this as we're now about to send out 24 letters requesting performance improvement processes to physician groups, and 7 letters to payers requesting performance improvement processes. But this then feeds into our analysis and back and forth discussion about it. Any thoughts from fellow commissioners before we move on? Great, I'm going to turn it back over to you.
Thank you. Okay, a time check, how long are we, Pardon? Yes. All right, great. Okay, so I had been asked to, if I was in a position to maybe share some of my thoughts about CHIA vision and priorities now that I've been on board for a couple of months, it's 9 months now at this point. And so this is a diagram I want to start off with that is starting to come together. You know, this is still a draft, it's a standard draft, but it's all right, there's nothing official about it. It's just kind of something that I'm noodling with to try to distill what I think of as kind of CHIA's core, not so much CHIA's core functions, it's more about our stakeholder ecosystem. And we'll talk a little bit about CHIA's, the box at the bottom that represents CHIA, but I think this diagram is really more designed to place CHIA in the context of its external relationships. So I thought that perhaps for purposes of this session, it might be a useful thing to talk through how I see CHIA interacting with other players in kind of its landscape. So, but this diagram tries to show at the bottom, in the box at the bottom is CHIA itself. And fundamentally what we do is we take in lots of data, about 25,000 file feeds per year from probably around 500 organizations pursuant to more than a dozen statutory regulatory data collection requirements. And we validate that data, we massage it into and stage it into various databases, and then we start to conduct various analyses and generate various measurements and statistics. And so there's 2 reports that you just saw from Steve McCabe relating to relative price and the confidential referral methodology. That's an example of how we take data and we actually work with it for some either statutorily required purpose or sometimes not statutorily required, but only through kind of the collection process and actually working with it, either generating statistics or publications, do you really come to understand if the data is sufficiently clean and is it usable and does it, is it fit for the purpose that you're using it for. So a lot of what CHIA does is inside that blue box, and that's really not what this diagram is intended to get at, but there's a lot of work that goes on in there. We also have well-developed processes in place for things like data sharing with other agencies, data release to external requesters. So we do more than 100 releases per year to researchers and the like, and for providing analytic services to state agencies. But it's those core skills that we develop doing the things inside the blue box that I increasingly want to see us leverage to serve the data and analytic needs of the stakeholder groups that are outside of the CHIA box. Before going on to the external stakeholders and kind of the nature of our relationships with them, I think it's worth pausing over the gold boxes or the yellow boxes at the bottom of the diagram. Those, in a lot of ways, and they're put at the bottom because they are utterly foundational. Those are the major categories of data that CHIA collects and curates, and that's a whole discussion. I think that in its own right, it would be interesting to do a presentation. And for CHIA's Oversight Council, we're working on materials to try to get them a better working understanding of our core data assets. But just in brief, there's the all-payer claims database. That's a saga in its own right. A lot of interesting things. It's a very, very powerful tool. It's been a difficult process in building it. It's exceptionally complex. It's not a single thing. It's 6 different, very large, complicated files, including things like enrollment files. So an entire, large category of data, such as enrollment and all the commercial health plans in the state. That's actually just one little subset of the APCD. So anyway, a large, complicated data set in the APCD. There's a hospital case mix database. It's a completely different thing. It's very mature. It's much older. It's also heavily used by researchers. I think sometimes external entities tend to think of CHIA just as the APCD, and then you remind them that there's also the case mix, and then they say, yes, that's right, there's also case mix. But moving further to the right in this diagram, the provider financial and cost reports, a lot of what we know about the financial condition and the expenditures in the Massachusetts healthcare system come from very elaborate cost reports that we collect, not just from hospitals, but from nursing homes and home health agencies and all sorts of other community health centers, all sorts of other provider organizations in the system. So We have lots and lots of data on costs and expenditures and financial condition of provider organizations. Health plan expenditure reports, the information that Steve McKay was going over, total healthcare expenditure, the way we generate that, it's not from the APCD, it's from aggregate reports that we get from health plans telling us how much did you spend by product, by, it's broken down in a whole bunch of different ways, but those system-wide aggregate measures that we develop, such as total healthcare expenditure, that's something that we get out of aggregate data reports from health plans. So the APCD is wonderful, and it's a critical tool in our arsenal, but a lot of people tend to think that it underlies everything we do. It doesn't. For instance, total healthcare expenditures, that comes from these health plan expenditure reports. Moving further, next box to the right, the employer, household, and patient experience surveys. I initially was somewhat skeptical of the value of survey data when I got to CHIA. I've really become a big fan of what we know about the market and the experience of individual families and employers and what motivates them to offer insurance or not, and what motivates individuals to take up insurance offered by their employer or not, and lots of very important things about the dynamics underlying our healthcare system come from the employer and the household surveys. So that's a very important bit of data we have. Quality data, this is an area that I think more needs to be done. We're trying to figure out, or more needs to be done. I think at this point in time, CHIA is looking to partner very closely with the Health Policy Commission and with EOHHS on the Quality Alignment Task Force that's underway, and we want to support that and have that kind of guide what we think about in the future for quality data activities. And then lastly, I'll mention the registered provider organization data. All the data that I've mentioned up until now under CHIA's domain, none of it really was specific to doctors. It's all hospitals and health plans and other provider types than hospitals. It didn't include doctors and doctors groups. So the registered provider organization data, which we're collecting in partnership with the HPC, that's a major advance in terms of CHIA's visibility into the healthcare system. By linking that to other things, it will dramatically expand our ability to measure certain aspects of the healthcare system. But we also think that there are just more pedestrian services, for instance, directories, and just more visibility and transparency into the system by having better rosters of physicians and their affiliations and so on. So anyway, that's CHIA. As I said, what we try to do is leverage this to support external stakeholders. And the state aid, box one is state agencies, because that's fundamentally, and I drew it in such a way that it's essentially connected to CHIA. We don't really see a large degree of separation between ourselves and our external state and other state agencies, other than limitations imposed by budgetary constraints. But we see ourselves as a core part of our mission as serving the data and analytic needs of state agencies. The next box, healthcare delivery system, box two, we see that as a completely unique set of stakeholders for us. They are the people, unlike anyone else in the world. I mean, these are Massachusetts regulated provider and payer organizations. They're extremely heavily regulated. They are the people that fund the CHIA. All of our data, by and large, comes from these organizations, and their day job is to handle huge amounts of sensitive patient healthcare information. So we think that there has to be a way to structure relationships with the delivery system in terms of access to CHIA data and access to data services that's on a different plane than with anyone else other than state agencies who are truly kind of the inner ring. Beyond that, however, there's two other external constituencies that we are focused on serving, one being the private sector digital health innovation economy. Massachusetts is home to a lot of companies in the innovation sector, in the e-health and digital health space. We want to be able to support that as best we can, consistent with all the legal restrictions that are in place. But we do think that since it's possible to use the state and the Executive Office of Housing and Economic Development, or maybe some of the state quasis, to create something of a gated community where, with data use agreements and the like, we can come up with some data sharing ecosystem that makes Massachusetts a better home for digital health companies. That's something that we aspire to support. And then lastly, I'll just mention our transparency website. I have a slide on that, and I'm going to go into a little more detail on that. But since the transparency website doesn't require patience, and by the way, we think the needs of small purchasers, small businesses, are very similar to the needs of patients in terms of needing to understand the healthcare system, the dynamics of the healthcare system, the costs and the quality of the players in the system. So we see those as two communities that we're trying to serve by the transparency website, but we don't require any kind of registration or sign-in, so there's no private information, there's no data use agreements. So that is fundamentally a website. Anything that you could get there is something that could be, by definition, just posted on the web. But we do take our transparency mission very seriously. Anyway, so that's just, I just wanted to run through that slide quickly to orient folks in terms of that's how I'm thinking about CHIA and how we interact with all the different types of stakeholders in our ecosystem. State agencies first and foremost, the delivery system is a utterly unique and critically important set of stakeholders for CHIA, a strong desire to support the digital health ecosystem, and then also a real commitment to serving consumers and small purchasers through the transparency website.
So before you move on, Ray, I just want to provide a little bit of context for this committee. Obviously, the collaborative and strong partnership between HPC and CHIA is just absolutely critical to the HPC continuing its work. And I think if you want to just flip back to that previous slide, Ray, you know, we utilize every one of those different gold box data sets in everything that we do at the HPC. And so having a strong relationship, having a collaborative and working relationship with CHIA is just so important to us. And I just can't say enough about Ray and his leadership at CHIA, and just, as you know, committee members. Ray, as you know, came in to the organization less than a year ago during a time when there was some budgetary considerations to be made. The legislature and there was a law that was passed that transferred a portion of the CHIA's annual budget to a new trust fund that was spent to support community hospitals, $5 million in the current fiscal year, and up to $10 million in the next fiscal year that would be transferred for those purposes. And Ray came in and really, and his team have just been excellent in focusing the work of the agency and being able to meet that budgetary challenge while maintaining and strengthening its core role in a lot of these ways. So I just, you know, we as the HPC and the CTMP committee have had a great relationship with CHIA over the years. We've asked the executive director from CHIA to come and present, you know, pretty much on an annual basis, just to give an update on the key work that they're doing. And I just want to publicly commend Ray and just let you know, committee members, that we have a lot of confidence in this relationship and in this work. And so Ray's going to talk a little bit more about some of the new things that they're doing, but I wanted to give that context for you guys, and hopefully, you know, if you have questions of him and you know what their work is going forward, you know, Ray's willing to do that.
But enough of the next one. Can you just give us a couple sentences on the quality data and the statewide quality measurement system? And the reason why I'm asking is because we still continue to hear all the time from providers and payers that they would love the state to be able to put it together so that they don't have to do it all individually and get different answers from each different plan, and so on and so forth. So I'm just sort of curious about how that's going, what its timetable is, what kind of data it's going to have, things like that.
Right. You would think that kind of from the names that's actually the role of the SQUAC and the SQUIMS, the Statewide Quality Advisory Committee and the Statewide Quality Measures. There were the statutory realities of how they're designed and how they're set up. There was a certain mental model in mind at the time, I think, relating to limited network plans and the like. It was, I think that there's very good people and there's good work that's been done, but they aren't really designed to be kind of overarching quality harmonization bodies. And when that realization came about, it was really through the HPC and now EOHHS working with the HPC that I say that the SQUAC and the SQUIMS are going to continue to perform their statutory function. But I think getting at what you're talking about, I think Alice might be in a better position to speak to EOHHS's efforts and David as well.
Sure. So EOHHS, HPC, CHIA, TPH, and a variety of other state agencies have pulled together. And many thanks to HPC's leadership on this topic, and I know that comes directly from some of the criticisms that we've heard from the cross-transference. But the quality initiative met yesterday for the first time. It has two different projects. One is in the short run, advising and assisting Medicaid, Mass Health in how to build quality standards in to the new waiver. That is on a rather short time frame. And then the second piece of it is extending quality measures, really considering how many quality measures are out there, how are they being used, how are they being operationalized, how do we reduce administrative burden, and fundamentally, and most importantly, how do we improve health outcomes? And so that is ongoing from now through year end, and then in the calendar year 18, the goal is to really build in, assuming that we have reached buy-in from the commercial world, really build in the DPH behavioral health standards, LTSS standards, and population health, social determinants of need. So it's an iterative process, which will go through, I'm sure, many transformations over time, but many thanks to CHIA, who does have the squad, does have the SQUIMS, which will continue to operate. And it's not out of the realm of possibility that as part of this working group, it will become more clear what the right statutory framework and regulatory framework should be going forward. But at least in a voluntary way, HPC has been a tremendous leader in pulling this initiative together, and kudos to Katie Barrett and folks at the HPC for that.
And I would just add, in addition to that effort, we have, I think, continued to think about and will continue to think about what is the state's role in terms of potentially being a hub for some of this clinical quality data, and that can provide a lot of benefits and values in terms of reducing duplication and administrative effort across their health plans and providers. And there are models in other states that we're looking at and thinking about in terms of more of a clinical data repository. That's a little bit further down the road, but I just want to say that we're also thinking about that and what potential role CHIA could play in something like that, or the highway.
So just continuing with, so this particular slide didn't do anything to, or doesn't talk about CHIA's publications. In the interest of time, I'm not going to go one by one through these, but it's another way of slicing and dicing what we do. I think the previous slide where we look at our data assets and our stakeholders, I think is a formulation I like better. We could also look at our data assets and then the publications we create from them. So anyway, I haven't quite figured out how to work this part of it into the overall slide, but it's only by creating these publications that I think we really understand the data well enough to be able to provide data cuts to other state agencies or to external users, to provide analytic services, to really say what the data means and what it can support and what it can't support. So here's a list of publications that we produce. It's a kind of a heavy annual load of activity, but it's really essential to understand the data, and it also performs a really important purpose in terms of getting those basic measurements and statistics about the healthcare system out there. So anyway, like I said, I won't go through the meat, but that's our roster of major publications. As we think about our data assets, as we think about our publications, and I've said before, I think that if you look at what separates, or what CHIA's unique value proposition is, it's not our ability to do analysis, because this is after all Boston, and there's lots of really advanced analysts and all sorts of organizations. Fundamentally, it's our ability to create data sets. It's our ability to, by statute and regulation, to pull together data that didn't exist in an aggregation, before we came along. And that's a power we have to use carefully, because every bit of data we collect is a burden on something. It's certainly a burden on us. There's a cost associated with collecting it and doing something with it, but it's a burden on the submitters, and we don't take that lightly. But we want to be sure that we're being absolutely optimal in terms of what data we collect. And so we are starting to think about and looking across our range of data collection activities to understand, are we doing enough in the area of pharmaceuticals? Are we doing enough? And we do have an updated specification there that's been well received, and we'll be getting more visibility into pharmaceutical spending as a result. The things around behavioral health and substance use, we know we aren't, that we can do better. We have a new behavioral health data collection spec that's going into place where the case mix data we've collected for decades from acute care hospitals will now be collecting that same data from behavioral health hospitals. So that's a really important expansion, but we know there's more opportunities like that. Quality measurement and reporting, Alice and David have spoken to activities are underway right now, but we see ourselves, always being an active player in that space. Real-time and HIE data. The stuff CHIA does is great, but it tends to be highly retrospective. A lot of the things we do, it has to be retrospective. For instance, one example, the Connector Authority has used our data for risk adjustment purposes. That's not something they do, halfway through the year, 3/4 of the way through the year, preliminarily. I mean, they do it once, they do it officially, and that's kind of the that's it. Well, in order to do things like that, you need a full year of data, and you need 6 months of run out, and then about a month of processing time. So the data is just inherently 18 or 19 months old at the point in time that it's generated. It's not because anybody's being slow, it's because that's the nature of the beast. But having said that, there's a lot of things that you can learn from real-time data, the data that's flowing across health information exchanges, and we want to understand, can we do a better job at that? Clinical data, we don't ever see ourselves being a repository, but we just want to, at least not a significant one, but apropos of the previous conversation about clinical quality measurement and the need for some clinical data, and the possibility that the state could simplify the landscape by doing something once that's otherwise happening many, many, many times. Maybe there's a role for us in clinical data. Data linking, we know, is going to be a big part of our future. Increasingly, we're finding that the most interesting questions and analyses are where other agencies come to us and ask to link the APCD to external data sources, whether it's housing data or all the opioid linking that was done. So we've automated and invested a lot of effort and money into our ability to do linking between data sets. Social determinants, we're trying to understand what we need to collect to do a better job there. Disparities in care, practice pattern variations. And then lastly, predictive analytics. As I said, everything we do tends to be very retrospective. That's our role, that's our nature, but we're at least curious about what we should be doing more of a forecasting nature, or whether there's a role for us in that space. And then last slide, Dave, just a time check. I can go up to the top of the hour. Great, so the last thing I'll do is give you a quick update on CHIA's transparency website. We're under a statutory requirement to have a consumer-facing transparency site, but we've had attempts in the past that we've stood up, other state agencies have stood things up. We're in the process now of a new effort. We're taking a very kind of multi-agency, multi-stakeholder approach to it. We're trying to work with other state agencies and all the private parties that are impacted by this to develop a website. So the target audience, and I mentioned this on that earlier slide, is consumers as well as small employers. In a lot of ways, they have the same information needs. Ultimately, however, we think when you stand a tool like this up, though, it's often the providers and the payers that go and look at themselves and see how they rate compared to others. And so we are also designing this with the thought in mind that it could actually be the impact it has on the people being measured that's part of it. So we're trying to keep that as a design consideration. And of course, policymakers. I can't emphasize strongly enough that we're taking a very agile, phased approach to this. We're standing something up this fall. It will be phase 1. We actually think it's going to be quite good, but we're immediately going to be working on phase 2, and we'll immediately be working on phase 3. I'm not sure exactly when this will settle down, but I think it's at least 2 years of as many iterations as we can get through, because I think we will learn something each time we stand stuff up and get it pressure tested. So, and also just we know from a data perspective, there's things that we were able to do when we took the cut of data that is going to form the cube behind the lookup tool that's in this version 1. We know that we can get more data, better data in the future. So we're going to continue to iterate the website and add new features and functionality. As I mentioned, it's being developed in close collaboration with both state agencies, but we're also going to really work very hard to let the payers and providers and their associations have every opportunity to weigh in on any and all aspects of how we're doing this. Often people, at least I initially came into this thinking that there was a price, that if you just showed that you would achieve transparency. There is just no single price. I mean, people think they want a price, and it's like, well, is it the price they will experience? I mean, that actually they need to go to their health plan for. But is it the, is it the average that their hospital's being paid? Is it the price that their hospital's being paid by their health plan? Is it the, there's all kinds of prices, it turns out. And when you answer one question, very often leads people to have another question. So we're going to have multiple pricing views. We're going to have quality and safety information in there as well, so that it's, you have that context. We're also going to have a heavy emphasis on consumer education materials and tools. We actually think this is a great opportunity to engage the public in conversations about healthcare. And if you think of the genius of Google and how they've gotten so wealthy, it's they realize that if somebody enters the search for toaster, it's probably a very good time to show them an ad for a toaster. Well, by the same token, we're going to have very, very rich and elaborate decision support tools on the website. And if somebody does a search for an MRI, I mean, you normally can't engage a person in a detailed discussion about what you should think about when you're having an MRI, and what should you ask your provider if you're having an MRI, and what to think about in terms of the site that you would go to for having an MRI. But if somebody's on pricing tools searching for MRI, that's the time that you want to have that conversation. So we want to have decision support tools that when somebody searches for colonoscopy, that we have the best tool, the best information available of here's what you need to know, here's the questions you need to ask, here's how you assess the quality of providers in this field. This is really an opportunity to engage consumers in their healthcare more than it's a pricing tool. At least that's my conviction. So heavy emphasis on the consumer education and engagement tools. Similarly, we want to develop tools to help small businesses navigate the healthcare system and understand what they're paying for and how to use their money most effectively. Sorry, Tim. Provider and health plan. I should be flipping the pages like keep up it. You'd think I'd know my own slides. Provider and health plan transparency, compliance support. We do think that we have a lot of laws in place, and there's been a lot of good efforts to comply with those laws, but we think that maybe providing some support around how to do a better job complying with existing obligations could move the ball forward. And then lastly, CHIA has published lots and lots of data over the year. Every report we do is very often a data book associated with it. We want to take that from Excel spreadsheets and strip it down into basically raw data frames that you can access by, make it a searchable repository accessible via API, so that essentially all of our data is liberated and available electronically. And that's a quick overview of our transparency website. I think that's it. Any? I think that's it.
First, I'm especially delighted by box 2 on your diagram of the relationship with the providers of care, and that's crucial to the future as well.
Absolutely, we see that as an absolutely essential, and to pretend that they're just like everyone else, like, oh well, sort of, we can, some stuff we can share, some stuff we can take away. There's got to be a way to structure data sharing relationships with provider organizations that's utterly unique, given their utterly unique nature, in real partnership on these so they can grow and learn.
Could you just say a few more words about the social determinants and disparities elements of your data plan? How are you going to go at it? It sounds really cool.
I think that it's very, it's tightly tied to the bullet that I had right before, which is linking. And that's, you think about the opioid crisis, that's when it really became most clear to me, when we're linking to the Department of Corrections data. Because I thought about, wow, if you mine the APCD, what could you learn about the opioid crisis? And then when somebody mentioned linking it to the corrections data, I realized, well, nothing compared to what you could do doing that. Like the predictive power of adding that additional data compared to anything you could do with the most refined algorithms of sifting through the APCD. So it really brought home to me the power of linking the data. And so we just recently had a meeting with Executive Office of Elder Affairs. They're very interested in looking at how housing arrangements affect healthcare utilization and outcomes. And they know there are people in federally assisted housing. They know some of these facilities have a high level of social services, some have a low level, some apparently don't, whatever. They're interested in linking their people and APCD data to understand the utilization and outcome patterns for people that are in these public housing facilities that have a high level of support versus the ones that have a low level of support. So there's a major social determinant of health that we can actually start looking at by linking databases. So I think we need a strategy probably for what additional data needs to be collected, but I think having a really powerful capability and willingness to link data to other agencies' data resources is really how we can move the ball forward.
Just building up the areas of investigation, and clearly there's a lot of alignment between the policy priorities of HPC, the collaboration there shining through in the list here for further areas of investigation. And similar questions about the social determinants of health and disparities in care piece. The one area that didn't see that we've talked about is the increasing cost of long-term care and home care and nursing home services. Is that a different data set? Is that throughout the data sets? And how does that play into other areas? Is that seen as another area of investigation? How do we understand that a little bit more?
Yeah, actually, I should say that the list should have started with anything wanted by the HPC. Because we really do see ourselves. I mean, of the state agencies, they're all important to us, but there's sort of a pecking order. It's really EOHHS and the HPC are kind of the ones that we most need to. I mean, it's the truth. And Mass Health is sort of the 800-pound gorilla, if you will. And so there's just we're not doing our job if we're not keeping those agencies absolutely happy from a data and analytics perspective. So I should have added that as kind of the first bullet point, and we'll certainly add it to our list of the things that we're looking at.
I assume the public archive is something that currently exists, but broken down by LTC type costs and various types of costs. When you look at that, who do you see as the biggest users of that database? And why did you put it together this way in terms of allowing anyone to access it via an API? I think it's great.
Right.
And how did you come to that conclusion, and who would be the most likely users?
Well, I think that it's, these conversations we're having with the digital health ecosystem, community in Massachusetts is what made me think of it. But it's also just what I'm looking for data on our website. And it's not a criticism, it's just the way people thought about building websites back in the days. You'd have to navigate to our annual report website. You'd navigate to the 2015 annual report, you'd click on that, and then there'd be a link where you could download the data book. We just want to make it a searchable repository where every one of them has essentially an API address, so you could programmatically extract any of the information you want. So it was just a realization that this is how agencies, and I've done some work in the past in the open data movement, so it's the modern way of exposing your data to the world is through APIs rather than having them downloadable Excel spreadsheets.
Is it going to be difficult to protect the data?
Well, this is only the data that you can get off our website. So this is not data that you have to come in and do a research request. We still have data that's protected that you have to come in and show us your credentials as a researcher, and we have to validate that it's necessary for the study that you're doing, and you sign a data use agreement, and it's all that type of stuff. But independently of that, if you go and look at one of our annual reports, there are copious amounts of data that back that up, that it's aggregate data. It doesn't relate to an individual, but it's elaborate information on the payers and providers in the state. But you have to go and download it and go to tab F and say, oh, that's what that is. We want to make it all available programmatically and in a searchable repository.
I'm going to use my prerogative to ask one question, Ray. One of the things that the HPC spent a lot of time thinking about last year was the impact of the GoBA decision on the APCD. And so I wondered if you could just reflect for the committee a little bit of what work you've done in analyzing what that impact can be and what you see as the continued utility of the APCD moving forward.
Sure. I mean, it's not as if it's not a bad decision, or not as if it's a decision that doesn't create challenges for the APCD, but the self-insured commercial population, although it's about half of the commercial population, if you look at the total data that we're able to access between Medicare and Medicaid and other things, and the fact that we can get some self-insured data, for instance, the Group Insurance Commission is the largest self-insured employer in the state, and recently Tufts Health Plan, they polled their self-insured employers, and about 30 to 40% of them voluntarily agreed to submit their data. So we think that the gap, it's only about 25% of our total claims data, denominator. But with voluntary compliance, we can reduce that further. We also think that the gap is fairly predictable. There's many ways in which a self-insured employer looks just like a fully insured employer, or at least their networks or the care that their employees receive. In some cases, there is a difference, and we have to model for it. But it's not a small problem, but we think it's a manageable one. There's other challenges around the federal substance use disorder data sharing, the SAMHSA regulations, 42 CFR Part 2, that are even more challenging, but we think we have a solution for that as well. But the APCD, I think it will never be the single source of all things, but whatever its limitations and challenges, we actually do think it's a really critical tool for understanding and measuring the healthcare system in Massachusetts.
Has Blue Cross gotten voluntary
Not yet, although in their defense, when I came on board, we were too busy sort of with other priorities, and we've been trying to sort out, a number of things, and so I've not circled back to the payer community to push them on, kudos to Tufts for having followed through and having actually reached out to their accounts and having gotten voluntary compliance. We intend, once we've, and we can always reach back and get data, so it's not as if the data's gone forever. I mean, we can always do a reach back. We do intend to talk to the health plans about getting voluntary compliance.
Thank you. I look forward to seeing ads from CHIA when I search for a toaster.
Exactly.
Do I know that whole wheat bread will make my colonoscopy? I think I better talk this way. Let's move on. We want to the first part that Steve spoke about was quite related to the performance improvement plans. So I want to turn over the discussion to the process. David, are you going to lead it off, or are we going to?
I'll just frame it up really quickly, and then Kara will take over. I think actually, Commissioner Cutler, you pretty much summarized this part of the presentation already, so I think we can move through this pretty quickly. But did want to just provide some information around next steps in terms of, as you said, this is not the end of the process, but really the beginning of the process in terms of the HPC's role here.
Exactly. So just a quick recap so that the differences between last year's process and this year's process will be even clearer. Looking at the 2016 process, which is on the slide before you, CHIA referred, as Steve described earlier, any entity who had HSA TME growth greater than or equal to 3.6%, either in their final 2012 to 2013 data or their preliminary 2013 to 2014 data. And because that list was based on 2 years rather than 1, it was pretty substantial, 25 providers and 8 payers. And you'll see on the next slide that this year's list, which we are in receipt of, looks much smaller because it's based only on the final 2013 to 2014 rather than on 2 years. So last year we received that list, we performed the gated review process that you're all quite familiar with, and determined that we needed to follow up with 3 providers and 1 payer. We did that. Dr. Cutler described that process a little bit earlier and ultimately recommended against any picks. So this year's list includes 14 providers and 6 payers. The slide that Steve showed earlier that shows the difference between entities referred under the original referral methodology and the new referral methodology has larger numbers because those are books of business that were referred, but a single payer or provider can be referred for multiple books of business. So the actual number of entities we're looking at, 14 providers and 6 payers. Obviously the list is confidential, so we can't tell you a ton about what's on it in this setting, but wanted to just do some very basic descriptive statistics for you. This slide looks at, for each entity that was referred, how many books of business they were referred for. And so you can see that the majority of both payers and providers were referred for a single book of business, and that 2 and 3 are the next highest categories. This actually looks very similar to the 2015 list if you were to break it out in a similar fashion. And then the next slide here refers to what types of insurance category the entities were referred for. So here we've switched from entities that were referred to books of business that were referred. So we've jumped from 14 providers to 26 provider books of business, and from 6 payers to 7 payer books of business. And here again you can see a significant cluster here in the commercial space more so than in the Medicare or Mass Health ComCare space. This is also consistent with the 2015 list. And you'll recall that last year we did want to pay particular attention to the commercial space when we were doing our review process, given what we know about provider price variation, about how these contracts are subject to negotiation and market leverage in a particular way. So this will continue to be an area of focus in our review process this year. Commissioner Cutler, you did an excellent job describing the process moving forward. So if there are any questions, we'd be happy to take those, but I don't think we need to go through the steps. The only thing I'll say is that we do have the list. We have validated it, and so that will be shared with all commissioners very shortly. If you have any initial thoughts or feedback, please feel free to send them to David Seltz or Chairman Altman or Commissioner Cutler. And other than that, the next step in the process will be for us to begin the gated review process and share those results with you. And in terms of timeline, we'll do the gated review in the next couple of weeks. That'll be followed by follow-up meetings. I will say that the timing last year was relatively similar, even a little bit earlier, and so we were trying to schedule follow-up meetings last summer as well. Obviously, that can be a little difficult, but with entities taking this process very seriously, wanting to have many members of their key staff present. So the earliest I think we would be back to you for a potential board vote would be September.
So great. Seeing no questions on that, we did move through that. I think we're ready to shift into the second half of today's meeting. Before we do that, I would like to return and ask for a vote of Commissioner Cutler. You can tee this up if you want to just tee up a vote of some of these minutes here for the CHICI committee. It's been a while since we've had a full quorum of the CHICI committee, so hope to approve a couple of sets of minutes as I click back to where those were.
Very good.
Sally?
I will just then tee it up by noting that I believe there are 2 minutes of recent meetings of the CHICI committee for which the minutes need to be approved. One was February 24th, and the second was March 22nd. So let me ask whether there are any corrections, additions, subtractions to the minutes. Okay, so I believe someone from the CHICI committee then needs to move that they be approved. And is there a second? Second? Okay, then those members of the committee, all those in favor? And any opposition? Very good, those minutes are approved as well.
Great, thank you for that. And so moving into the second half of this meeting today, we're going to be spending the rest of the hour here really focused on the Chart Investment Program. And so very glad to have commissioners here. 3 parts to this presentation. First is a discussion and to share with you some information that we've developed around our learning and dissemination strategy for lessons learned through the Chart Investment Program and through our other certification programs. Second is an update on our third-party evaluation of Chart Phase 2 that BU School of Public Health is conducting. And then finally, a discussion around our program design for Chart Phase 3. So first, to tee up the strategic investments learning and dissemination strategy, I just want to really contextualize this by saying this has been something that we've heard from commissioners a lot over the last year and a half. We have these incredible investment programs. So there's these great programs where across the Commonwealth, hospitals and different providers are really implementing new and innovative ways of delivering care. What is the HPC strategy in terms of taking those lessons learned and spreading that and maximizing the impact of all of the work that we're doing? And so we took that challenge on in terms of hearing that from commissioners and having a strategy to do that. And so we spent a fair amount of time over the last really year in terms of thinking about what is the best way to do what we call learning and dissemination. So interested in your feedback on this strategy as we begin to roll this out. And so happy to turn it over to Laura Melby here, who has been our lead in developing this. So I'll turn it over to you.
Thank you, and good morning. To further frame the conversation, we've been talking informally a lot over the last year or so about learning and dissemination at the HPC. You might recall in last year's cost trends hearing, there was some good discussion and questions about how we're going to diffuse information from our investment and certification programs. And so we're excited to come before you today to present a more formal plan and process that we've been developing, as David said, over the last year. And so as you know, we are learning a tremendous amount from our cohort of certified providers and investment awardees every day. And we know that we're going to get some excellent learnings from the programs that we'll be launching over the next months and years. We're learning about the challenges that our cohort faces, the successes that they're experiencing, and so on. And as you also know, we've designed our programs to promote learning and shared learning to ultimately be disseminated to a broader audience. What's working, what isn't, and so on. In our role as a convener and a partner, we're able to gather shared learning gleaned from these programs and from their partners to share it ultimately to further the HPC's mission and advance the triple aim. And so we recognize the need for a thoughtful and cogent plan to share what's been learned from our programs. And so over the last few months, our team has engaged in learning and dissemination, strategic planning, and activities. We're thrilled to share our initial findings from these activities that include an environmental scan, a lit review, a survey, and subject matter expert interviews. So several months ago, to kind of kick things off, we convened a meeting of leaders and managers at the HPC with the goal of identifying a focus and goals of learning and dissemination, or L&D. And as I mentioned, as David mentioned, we will focus our learning on our care delivery initiatives, our certification programs, and our investment programs, currently ACO certification, PCMH Prime, our chart investment program, and our innovation investments. At that same meeting, we also developed concrete goals for L&D, and those goals are twofold. So first is to curate and share practical, and I'll underline practical, approaches, effective models, and sustainable practices and lessons learned with providers and leaders and decision makers within those provider organizations as a primary audience, and payers, state agencies, and policymakers as a secondary audience. Our second goal, we'd like to endeavor to become a trusted source for market participants and other stakeholders to find practical information to achieve the triple aim. We also recognize that throughout the life cycle of a given initiative or program, there are several activities taking place at once that may overlap or sometimes may feel like they have a similar or same purpose. And these are technical assistance, evaluation, and L&D. We define each of these for our purposes and feel that it's helpful to further frame the conversation about what we're doing. And so we understand that these are distinct work streams, but they should consistently feed and complement each other. And to that end, we've defined evaluation as understanding whether or not an initiative did what it set out to do. Technical assistance as helping a given entity reach its goals in an initiative. And L&D as broadening the adoption of promising practices identified within our programs, and perhaps also to share what's not working or challenges or barriers to success. And so as one last piece of background on our thinking about L&D, we found it helpful to plot how our goals may change and adapt throughout the progress of a life cycle of a certification or investment program. And so what you see on the slide, I won't go into details, is that our goals change and they shift as a program progresses. And the same is true for our investment programs. So our goals will change as the program progresses. During the planning phase, we might be more concerned with sharing external information with our cohort to help inform program design. During the implementation period, we might be more concerned with facilitating real-time learning and sharing promising practices that we're identifying in our programs with the rest of the cohort for adoption and adaptation as appropriate. And then at program closeout, we have the entire investment program in view from soup to nuts. And so we might put together some of the information or learnings or materials that we've identified throughout as a compendium, and then back that up with, say, a longer report or case study or what have you. And so that kind of summarizes our thinking to date about learning and dissemination, and so now I'll get into our research and stakeholder engagement process, unless there are any questions. Great. So as I mentioned, we conducted an environmental scan to identify dissemination methods out in the world that we may wish to emulate in our programs. And we also conducted a brief literature review to identify any known best practices in L&D. And what we found, as you can see on this slide, that nothing here is earth-shattering, nothing here is surprising, but it did help to validate our assumptions about how to best share information with our audiences. The first two findings here indicate that dissemination is an intentional, active communication process. The second two findings note that repetition of information is key, and that sharing information in multiple ways through multiple channels is critical. As an example here, we could produce a white paper discussing the benefits of having a pharmacist on a multidisciplinary care team, and then further reinforce our message, say with a webinar with a panel of pharmacists. Any questions here? So now we'll move into our survey and subject matter expert interviews. In April, we distributed a survey to a broad group of stakeholders across Massachusetts to get a better idea of what folks want to learn about our programs, how they'd like to learn it, and what has worked for them in the past in terms of resources and qualities and so on. In the past, when they've engaged in similar care delivery initiatives. As you can see here, most respondents represent medical providers, some are behavioral health providers, and the majority of respondents hold either management or leadership positions in their organizations, and some hold patient-facing roles. And we'll get into some of the results in a moment, but following the survey throughout this month, we conducted interviews with subject matter experts, 5 interviews, to better understand from folks who have really impressive track records of sharing information in a thoughtful and effective and polished way. And so those organizations were Boston Healthcare for the Homeless Program, Connecticut Health Foundation, IHI, CHCS, and the Blue Cross Foundation of Massachusetts. So there are 3 key takeaways that we'd like to share with you today from this process. The first is that our stakeholders are interested in a wide range of topics, basically the full scope of what we do with our investment and certification programs. And our interviews suggest that while we were a little bit scared with this result, we kind of hoped for one silver bullet, like, yes, we should focus on this single thing. Our interviews told us that it's actually a very good thing that our stakeholders are interested in such a wide range of topics, because we can retain flexibility in what we share and how we share it and how we prioritize. The second item here, and as our literature review found, our stakeholders want information to be shared in multiple ways through multiple channels. Our subject matter experts also told us that using a multi-layered approach to sharing information can help meet this need. That we can design our materials in a modular way that allows us to tailor and repackage information as needed. The third takeaway here is that stakeholders want to receive information in multiple ways, but they find the most value in succinct and practical information, or snackable information, as one person told us. Materials like infographics, briefs, and one-pagers. The experts that we spoke to agree with this, but said that reinforcing those snackable materials with evidence is, of course, very important, where we can do that. So unless there are questions, I will just dive into each of these 3 findings a little bit further. So the first item here is topics and flexibility. From our survey, we learned that stakeholders are truly interested in a broad range of topics. But there are a few that stand out. The first that stands out are topics relating to behavioral health. These were among the highest rated across all respondents. These include, among other things, behavioral health integration and care management for behavioral health conditions. Respondents also, unsurprisingly, note a strong interest in programs to address the social determinants of health. Subject matter experts told us that interest, again, in such a wide range of topics is a good thing. Again, it allows us to be flexible in what we share, when and with whom we share it. Our second item here is how we share information. How do people want to receive information from the HPC? We learned that stakeholders like to receive information in multiple ways. They find real value in peer-to-peer learning activities. We have heard over and over again from stakeholders and experts that to do this, and I think we all know this, those activities have to be incredibly well organized and facilitated. Respondents also find practical tools and technical resources to be very useful, but they also note that while short and sweet is nice, program results, full evaluation findings, and evidence are of value. So it will be incredibly important for us to balance the methods and channels by which we diffuse information. Experts, again, validated these findings, which indicate that there's a desire for for a modular or layered approach to sharing information through multiple methods of communication. And finally, in terms of what we're sharing, a clear favorite among respondents is to receive information in a succinct manner, infographics, tools, briefs, and so on. But again, supplementing these materials with evidence helps to reinforce the message. So we need to balance the practical with the lengthy and the robust. And when we do develop lengthy reports, that organizing them in such a way that information can be found easily and quickly is, of course, incredibly important. So the last thing I'll note on this slide is that we went into this process thinking that we should always start with the long report and then pull out nuggets of information to create infographics and briefs and one-pagers. But what we've learned from our conversations is that there's actually value to doing it in the opposite way, and for our purposes that may make the most sense depending on where we are in a given program and what information we have at hand. And so during implementation of, say, Chart Phase 2, we are actively trying to share promising practices from the cohort with the cohort for adoption and adaptation. And at program close, we can again create a compendium of those documents supplemented by a longer report. And so next, just a very high level idea of what our next steps look like. We presented some initial results to you over the next month. We're going to complete a full analysis of our survey results and interviews. Over the summer, we'll draft an approach to learning and dissemination, and we will formally launch these activities in late summer, early fall. And I'll stop for questions.
I'm just trying to think about which area we want to be exploring first. I mean, we've spent quite a lot of time on post-acute care services, and excessive hospitalizations and so on. So I was listening to this with that in mind, and I was kind of thinking to myself, you know, how does this fit with that? Like, is that where we want to go?
I think there may be a range of different topics. I think certainly with the CHART program, and we're going to hear a little bit of some of our evaluation results from CHART in a moment. Those are the primary aims for most of our CHART programs right now are reducing readmissions, reducing avoidable inpatient admissions, reducing ED visits, and reducing ED boarding. So that is very much in the mode of how do we target high utilizers of our healthcare system, many of which are very complex, who have comorbid medical and behavioral health conditions, are impacted by social complexities, and these programs have been in place now for a year and a half. So I think there's a wide range of topics there that one can think about that are very much in line with the overall strategic priorities of the agency, specifically around reducing hospital utilization. And that's one. And I would also note, and one thing that we're constantly thinking about is the Mass Health program and their restructuring and the launch of their ACOs in January. And so now we're going to have a whole new audience of providers who may not have been in the CHART program, but who are nonetheless going to be working on the exact same types of challenges and programs and goals and outcomes that our CHART program has already gotten a little bit of a head start. So how can we feed into what providers and other organizations need to know, even in a short order here, in order to be successful in that program. So that's certainly one area that I think about, Commissioner Cutler, when I think about where we can feed into this broader environment.
Really nice. Once you got this one. Really nice report. Thank you. I love the focus on learning. That's my thing. So I have three thoughts. One is to David's point first. The CHART program's potential in the future seems to me to be great in one of the implementation routes for aligning the priorities that emerge from the cost trend area. The Commission's list of targets for cost reduction is a tremendously promising list.
for action of this type. Second, in my experience, your emphasis on peer-to-peer learning is key. 84% of people said that was the best. That also generalizes to peer-to-peer ambassadorships, in which if we want to take a chart lesson and move it out to a non-chart place, the best people to do it are the people at the chart place that did it, and then can go out and be teachers. And I'd encourage you to think about commissioning people to do that in some way. And the full form of that I tried to get done when I was running CMS, but for reasons we'll talk about over here, I couldn't. I think there'd be value, and I mentioned this once before, in having HPC fellows in every hospital in the Commonwealth, maybe every hospital in practice. A fellow would be a person, clinician, manager identified as having continuous relationship with HPC around chart and chart-like activities, kind of like the tight end is going downfield to catch the ball if we throw it, and also a great source of ideas. So offline, if we want to talk about that, this is a brainstorm idea. Yeah, I'd love to explore that. I don't think it's expensive.
Thank you.
All right, seeing no other comments and questions here, thank you, Lauren. So for the next update here, happy to bring up Jessica Lang, who has been our lead in working with the BU School of Public Health, which is conducting our third-party evaluation of Chart Phase 2. Again, Chart Phase 2, the largest phase in this program, $60 million investment. So critical that we have a robust evaluation. And so we'll spend the next 15 minutes or so just sharing with you some of our initial results that we've been getting from BU. BU has been out in the field already interviewing our hospitals, and so I'll turn it over to Jessica to kind of walk you through some of our initial results, which are encouraging.
Thank you. So as David said, I'm here to give you all an update on the progress of the evaluation of Chart Phase 2. The purpose of this evaluation is to derive maximum insight from Chart Phase 2 initiatives. And so we've contracted with a team at Boston University School of Public Health to conduct this mixed methods evaluation. The framework of this evaluation was borrowed from one that was developed for evaluation of large-scale CMMI programs, and it considers 3 high-level domains. First, implementation. Did they actually deploy the intervention they planned? Second, impact. Did it work as designed? And finally, sustainability, were there long-lasting changes produced? We're approaching this through a combination of quantitative and qualitative methods. That includes analysis of data from CHIA, case mix data, site visits to the hospitals where staff involved in the initiatives are being interviewed, and surveys of the hospitals, and finally a patient perspective study. This summer, by the end of the summer, we will have an interim report that describes the performance of the initiatives during the first year of Phase 2. But meanwhile, I'll whet your appetite with some early findings regarding HPC engagement with the chart hospitals, the state of utilization at baseline in the cohort hospitals, and ACO readiness across the cohort. To start with, the program managers at chart hospitals were surveyed to ask how they feel about their engagement with the HPC for technical assistance. It was encouraging to find that they all had quite positive feelings about both their program officers and the strategic advisor who had been contracted to work with them. They highlighted collaborative learning opportunities like convenings and the chance to share protocols with each other as being especially valuable. They also mentioned measurement and analysis and clinical processes, as well as post-acute follow-up as particular topics that they benefited a lot from technical assistance. In open text comments, a number of hospitals expressed frustration about lack of clarity early on regarding measurement and measurement burden, and a number did express appreciation for the measurement reduction and increased clarity and focus that's happened later on in the program. Now, as I mentioned, there will be quantitative analysis based on case mix data of the impact of Chart Phase 2. As a first step in that direction, the BU team has analyzed case mix data for the 2 years prior to Chart Phase 2 and done some calculations for the chart hospitals as a group and some comparisons to non-chart hospitals. At the top, the average 30-day readmission rate and 30-day ED revisit rates were pretty constant over the 2 years before the start of phase 2. They also were very similar at chart and non-chart hospitals. The average ED revisit rate for the subset of patients who have behavioral health diagnosis, though, it's higher than the general population, and it's higher at chart hospitals than non-chart. That generally was not a surprise. That felt consistent with other indicators that chart hospitals are disproportionately taking care of more socially complex, more vulnerable patients. The analysis also looked at leakage to other hospitals, readmissions or revisits that started at one hospital and they came back to a different hospital. That varies widely, largely driven by just are they the only gate in town or are they located in an area where there are other hospitals. Leakage rates are in some cases quite high, up to 60% for ED revisits in cases where there are multiple EDs available in the same geographic area. That's not surprising, but it does highlight that can be a big challenge for some hospitals, particularly ED-focused programs, because it can make it more challenging to identify the patients that they want to serve, to track the patients and see what the outcomes are, and to actually engage the patients. And finally, the analysis looked at patterns of patients who have high utilization. It's generally known that patients who are identified as having high utilization in 1 year often are not in the next year. Often there's a fluctuation in their utilization. Inpatient high utilizers, the majority are not high utilizers in the following year. This hadn't really been investigated before for ED visits in this particular way, and we found that about 40% of patients who were identified as having 10 or more ED visits in a year at a chart hospital did continue that pattern the next year. But that means that 60% did not. So there is less fluctuation for frequent utilizers of the ED than of inpatient services, but still the majority do not have a consistent pattern from year to year. And that, again, is something that is challenging for teams that are focused on patients with high utilization of the ED. So the full baseline report will be available on our website pretty soon. But before I move on to some qualitative findings, does anybody have questions or thoughts?
On ED utilization, do you break that down? Will you break that down in the report by condition, age, gender? Is that something that makes sense?
Definitely, there will be some subgroup analysis, and we'll see where there's useful findings. It's known that there are some differences across different demographics, and so we'll see. We do have target populations are a subset already of the population, so it may or may not turn out to be feasible to do all those breakdowns.
One thing that I saw in a study was folks in their last 2 years of life have significantly more, obviously, ED visits, etc. And it'd be interesting to see if you could actually, how you would actually look at that statistically, but apparently that's a significant portion of ED visits.
Yeah, and I know some chart programs really have focused on working with hospice and palliative care in order to try and reduce those ED visits in the final year of life. So that'll be interesting to see whether we can detect an impact. So then turning to not chart-specific but hospital-wide practices. So part of the theory of change at chart is that some of the practices that are pioneered by chart teams will spread through the hospital and support hospital transformation and PCO readiness. So in order to try and examine that hypothesis and in order to understand the institutional context that the chart teams are operating in, the hospitals were surveyed about their care delivery and information technology across the hospital. So this is information that's provided by investment directors or other people they identified as having knowledge of hospital-wide practices. So at the top, in some questions about behavioral health integration, the majority of hospitals do have behavioral health and medical providers co-located in the ED. Only about a third said that collaboration of the different provider types was standard, was formalized. So that is an area of potential growth. across the board. As far as what types of hires did they make for the CHART program, which we want to watch and see if that's supporting the development of their ACO readiness capacities. All hired new staff for care coordination, unsurprisingly. New staff for data analytics was also a very common new hire. The next two asked about where they are right now across the hospital in assessing inappropriate use of the ED and avoidable readmissions. And only a quarter and a third said that they feel like they are where they need to be in those areas. So these really are, these are areas where the CHART teams have the potential to lead the hospitals.
What do you make of those low numbers? That's really surprising.
I think those low numbers confirm that CHART is needed. I think that if we found that all of the hospitals, or the majority of the hospitals, said yes, we have a fully developed program, that that would be surprising. That would say either they're a little unrealistic or CHART wasn't really necessary.
I also would add, I think my reflection on this is partly in terms of the routinely and fully developed, that they do have perhaps, you know, for some specific target population, maybe under a risk contract where they're really thinking about this, but they're not thinking about this on a population-wide basis in terms of really kind of all payer, how can we design programs to address these two issues. So I think a little bit of it is in that wording too.
Yeah, I just wanted to say there is some nuance there that none of them said they were doing nothing about these things. But they were asked, there was a range of from nothing, little bit, a lot, really where we need to be, and the majority are somewhere in those middle categories. They were asked about use of telehealth, and most are using telehealth somewhere. None of the hospitals said that they were using it really across the board in multiple services routinely. A lot are using it in one or two services, stroke care being one of the more common ones. They were asked about using automated flags in their EHR to encourage hospice or palliative consults. We saw that as potentially an early sign of the integration of hospice and palliative care, to your point, and about not quite half said that they are beginning to use those flags. One thing that also emerged was the majority don't have a single EHR across the hospital. The ED and inpatient services may be separate, other kinds of differences. And so it did emerge as a sort of a pain point for a lot of the hospitals that it's difficult to get everybody on the same system. They were asked about their collaboration with other partners, and this is not CHART specific, this is about what the hospital generally was doing prior to or independent of CHART. Nearly all are collaborating with SNFs or other long-term care providers. Collaboration with police and fire is common, same with behavioral health providers and social services also common. Schools, about a third of the hospitals mentioned, though we're not sure really what type of schools and what that looks like. We asked them in a fair amount of detail about their use of health information technology, and found that there were some areas where consistently CHART hospitals have made a lot of progress and are quite strong, and there's a number of areas that are potential for growth for most of CHART hospitals. On the top, they are working well with pharmacies electronically, and most CHART hospitals do have an ENS that can notify physicians, at least within their provider organization, when patients are admitted or discharged. Most have been using patient registries for chronic disease and for high utilization. And most now have some ability, though not as much as they would like, to integrate patient data from providers outside their system. Some areas where there's much more mixed results, and where hospitals said that they are not where they would like to be, was predictive risk assessment and stratification. Using patient registries for behavioral health, electronic communication with patients, and sharing referral and follow-up information electronically. Now, I would note that all of those on the bottom are things that some CHART teams are doing really well and really pioneering. So those are areas where we may look to see if they are able to spread those practices and lead the hospital in a transformative direction. On this survey, they were also asked about their most critical community partners for the CHART initiative specifically. The most common responses were behavioral health providers, usually comprehensive providers of outpatient PH services, post-acute providers, and social services, particularly housing and food. We also identified some unique partnerships that only 1 or 2 hospitals were doing, but that I think are really ones to watch. These included hospice care, pharmacy, transportation, and courts. But these are ones that could turn out to be effective models that other hospitals are interested in replicating, so we'll be paying a lot of attention to those. These are some of the milestones in the evaluation. As I mentioned, we have the survey results of the hospitals have been analyzed, and the baseline for the quantitative analysis has created, and that report will be available online. Right now, the BU team is finalizing awardee memos. So each hospital will get a brief memo summarizing a few key takeaways about their successes and challenges. And those are confidential memos that is really meant to just be a useful tool for discussion within the hospital and among their stakeholders as they choose. Coming up this summer, we will have the interim report, and I'm hoping to invite the leaders of the BU team to come and speak at the HPC, so everyone will have an opportunity to hear more about their findings in depth. And then I'll move on to some next steps. Now, it's critical in trying to assess the impact of CHART Phase 2 to hear the voice of the patients that we're actually trying to serve. And so that's going to be done through the patient perspective study. The evaluation team has chosen a subset of sites that were chosen to represent a wide range of program types as well as geographic areas. And they will be working with the program managers at the hospitals to identify patients. There's an IRB approved process where the patients will receive a postcard asking if they're willing to participate, and they can opt out of being contacted. Then they will have, those who are willing will have a confidential interview either by phone or in home. And the team will, as necessary, follow up with having some focus groups in order to flesh out the themes that come up in interviews.
What percent historically, what folks you told you, what's the percentage of patients that are willing to actually participate, and do they fall into a certain category?
That's a great question. I don't know of any statistics on percentages. I think it would be highly variable, and I think we do know that there is some selection bias here, that some patients who are less willing to be contacted, there may be reasons, and that may affect results, and so the team is very aware of that. We are going to be working with program managers in order to make sure that we don't miss out on the voice of patients who do not have a permanent address. Some of our teams are working with a lot of homeless patients, and that's particularly important to capture. They also will be interviewing some patients who declined CHART services, who were identified as members of the target populations but didn't want to be enrolled. And we'll be interested to see what we can learn from that. So the team will be doing their best to work around that as an inherent limitation. Other questions on the patient study?
Less than the patient study, I'm just wondering what role at all in the interviews or any of this process that there was a conversation with the frontline caregivers, the workers that were implementing these plans and programs, and how's their opinions and thoughts about this taken into account in the report?
Yeah, so their perceptions actually are really going to be the meat of the interim report. So the hospital site visits, the team interviewed generally about 10 staff members at each hospital. In some cases, some community partner members as well. And also trying to include leadership and management and frontline patient-facing providers. And so the analysis of those interviews is really the most substantive part of the interim report that we'll have this summer.
Is BU going to do a financial analysis for the institutions, like in light of risk contracts, penalties, and so on?
No, we will have, at the end, we will have an estimated ROI, but that it will not be hospital by hospital.
But there will be one for a typical hospital to say, actually, in light of what's typical about contracts for you, this either makes sense or doesn't make sense.
We'll be trying to feed them the information that they need to do their own analysis, and we are talking with the accountable care team as we go along to try and make sure that we're providing them the information that's most useful. So, speak to them.
I would also add to that point, Professor Cutler, in chart phase 2, we actually set aside money for strategic planning for each of the hospitals, and have asked them to use, to really think about how they're using those dollars to do that exact type of kind of financial sustainability modeling that they need to do in order to make these programs continue to work for them in the future, and what is the benefit to them, and that really feeds into what we're expecting from them in chart phase 3.
Because the last thing we want is for a great program to go away because the money goes away.
Exactly. So, just being mindful of the time, there's a couple more slides here, and I think Professor Cutler on slide 62, you can see some of those potential ideas for theme reports across a whole list of different areas that we've been learning about in chart phase 2 that will certainly be part of both the evaluation and our learning and dissemination strategy. And on slide 63, the continued next steps for the evaluation. So I'm going to move us to the final agenda item here today, which is really around the next phase of this investment program. And so I'm going to ask, thank you, Jessica. I'm going to ask Kathleen to join us, Kathleen Connolly, who's the director of this team. We did talk about chart phase 3 at the last CHICI meeting, and have talked about it at previous advisory council meetings, and have the slides in one of our board meetings, but weren't able to get to it in terms of the discussion. So really the timeline here and why we're moving forward with a chart phase 3 design is that chart phase 2 is ending. Chart phase 2, the programs will be concluding at the end of this calendar year. And so they are eager to know what the next phase of this investment program will be. And to your point, Professor Cutler, what is their ability going to be to continue some of these really promising programs that they've put in place into the future. In addition to the timeline of chart phase 2 ending, we also are cognizant of the fact that MassHealth is launching their new ACO program starting in January. So this is a really incredible opportunity to line up our timelines in such a way that we're really phasing chart phase 3 into the launch of the MassHealth ACO program, and thinking about how we can set these hospitals up for success in that program. And that's really the framework that we put together this design phase in, is sustainability of this great work. And how can we make sure that we're not, as these grant funds go away, that we're not losing the momentum and the progress that we've been putting in place. And so that's the framework that Kathleen will talk about in terms of our next phase of this investment.
Thank you. And in the interest of time, I'll just flip through a couple of slides that we're framing that you heard from today about the plans for CHART to be a transformational program. And so as we get into this last phase of the program, we wanted to offer 2 pathways to our awardees to both continue the progress that they've made in phase 2, if they've had successful initiatives, but also prepare them to further develop the capabilities for ACO and being a high-performing partner in an ACO and transition to alternative payment models. So chart phase 2 hospitals can apply for one or both. The pathway 1 should be in the context of participating in an ACO or an APM. So in other words, to the point about sustainability, we want to ensure that these programs are providing great services and also represent the context of which the hospital is operating as part of an ACO or an alternative payment model. Yeah.
I hope we'll have more time to talk about this. This is so exciting. I'm going to have to go. But you had this slide, a quote from the community hospital CEO. I don't see any future for community hospitals. I think there's a fantastic future for community health systems. That's a really important notion. And I think it's great to align with MassHealth and the ACO movement, but there's a challenge here which we ought to think about, which is it's a higher level design challenge, which is what what is the community health system? What does it look like? Not just the list of stuff, but some architecture for what that means. And I think you've got the potential with this program of superimposing an inquiry that would lead to ideas for models. If I'm in Berkshire County, I'm in Greenfield, what should I be trying to build? It's a community health system. It's a bigger question than just how do I find the values purchasing. That may be a bad comment. I don't know.
Well, we'll certainly take time offline and go through this. I mean, we really do think of this as part of the framework for this investment program, and where we have been using these grant dollars to, in some cases, force these hospitals to do things that have been uncomfortable for a long time. And part of that is reaching out beyond the four walls of the hospital themselves and engaging the broader community, engaging different types of clinical providers, whether that's post-acute care, the behavioral health providers in their area, but also around the court system, the law enforcement system, the schools in their communities. And we think, we have heard that has been transformational in terms of how they think about themselves in terms of broader community. And there's a range, of course. Some hospitals have been more successful at this than others. But I think when we think about phase 3, we want to continue to push this concept of strengthening community partnerships as a key lever towards thinking about themselves, not just at the hospital, but also in terms of, as a community hospital, how do they fit into an ACO? An ACO that in many cases will be thinking about reductions in hospital utilization as one of their primary aims to save money. And so we have been testing and piloting that in a big way through CHART Phase 2. How do we ensure that they have a future and a voice within that ACO that is recognizing that a lot of the savings are going to be driven by reduced hospital utilization. And that requires changing how they think about themselves in terms of that ecosystem community. So that's one way of saying I completely agree that part of what we're trying to drive to and encourage these hospitals to is think about themselves both in a different way within their systems, but also in a different way in terms of the ACO. And that is going to be their big challenge for the next 18 months in terms of incorporating into the Mass Health program. And that's going to be, and we think though that the APMs and ACOs is the sustainability model. Without having a financial business model to continue these programs, it's going to be really hard for these hospitals to keep all of these people that they have hired, as you can see on this slide, on the payroll. Because if they don't have that business model, this becomes really difficult. And in many cases, most of these chart-funded FTEs, social workers, community health workers, care coordinators, patient advocates, what they're doing is working to reduce utilization at the hospital. And that, in many cases, is a revenue source for the hospital. Sorry for going on a little.
It's okay. We only have 5 minutes left, so I see folks flipping through the deck. Are there narrow questions that folks want to ask? I don't want to read to you.
I just want to follow up with a broader comment, which is this really goes at what we've been talking about in the payment system delivery, payment reform and delivery system committee, which is how to further push both for ACOs and for other kinds of alternative payment mechanisms. Doing so will dramatically increase the case for doing this.
Exactly.
That's
So
the sustainability model.
no, I know it's sort of sparked idea. The more we put things on a bundle or a technical care basis or whatever it is, then the greater the returns to doing this become. So I think it puts pressure on other parts of what we're doing also.
And that's why in phase 3, we want to offer some continuation of funding, but with a higher commitment from the hospital and also a commitment for them to work with their community partners and the ACO that they are participating in order to develop the business case long term for this, as well as do some capacity building around what it means to be a good hospital partner in an ACO.
So I think we've reached the end of our time here. So we'll touch base offline on some of the specifics of the design. We are hopeful to talk about this at our next board meeting on June 14th and move forward with a design and an RFP. Timelines are reaching up on us. So
With that, thank you very much, commissioners, for a great conversation today, and we got through a lot of material, which was really excellent, and appreciate your comments and feedback.
Thank you. Is there any other comments? We will be adjourned.
All right, Wendy, we'll let you go. Okay, bye.